Dr. O'Connell, thank you for giving us your time today. As you know, we're collecting reminiscences and interviews from people such as yourself who've played a major role in the development of not only the International Society for Heart and Lung Transplantation, but the evolution of the field. So it's a pleasure to speak with you today.
Thank you.
So you're a Chicago native, I guess. You did your training here, and your medical degree and your cardiology training, and graduating in 1974. What were the major influences in your career choice? Why did you decide to go into medicine?
I decided to go into medicine because I started working when I was actually 15 or 16 in a hospital, and I got to idolize the physicians and happened to be in a coronary care unit for the latter part of my time there, and I just thought that that's what I wanted to do, to be like them.
So the pathway into cardiology became clear pretty early on?
Well, yeah, it did. I think like everybody, I went through my evolution, but the reality was I started my residency with the intention of becoming a cardiologist.
So the first human heart transplant, you must have been a teenager or so?
Well, I was a freshman in college.
A freshman in college. So do you remember that? Tell us your reminiscences about that.
Well, I mean, I thought it was science fiction, and I still think it was science fiction back then. And certainly I didn't know any of the players involved like I had the great fortune of getting to know later on in my career. And I had no clue that somehow I would be in that field or that arena, or that it would be a readily applicable procedure.
Until?
Well, I probably didn't have a clue until I actually started getting involved with it. I finished my fellowship, and I had done research in myocarditis when I was a fellow, and endomyocardial biopsies at that time were being purported to identify people with active myocarditis, and many people thought that they may respond to immunosuppression. So I went out to Stanford in 1980 and learned how to do endomyocardial biopsies. Suddenly I became the only person in Chicago who did biopsies. So I had this huge referral base of very sick patients with cardiomyopathy who were biopsy negative. And what do I do with them then? Well, I got involved with beta blocker trials because it was just beginning to evolve as a therapy for heart failure. And after about a year of sequestering these patients, my mentor and boss brought me in and said, you know, Chicago needs a heart transplant program. Would you spearhead this project?
So this would have been in about in the early 80s? 81?
81, actually. And so I went out and spent, like everyone else in the country at that time, I went out and got to know Sharon Hunt really well and spent time at Stanford. Got to meet Norm Shumway and Margaret Billingham and the entire group of people out there, and developed friendships that actually lasted the rest of my career. I came back, and shortly after I came back, I thought, oh my gosh, how am I going to put together all of the organizational issues that are necessary to start a heart transplant program? I was very fortunate because my wife, who was an intensive care unit nurse, went out and looked at the Stanford Surgical ICU and got to know Julie Chin, who was the head nurse there. And she called us about 2 weeks later to say one of their nurses had just moved to Chicago, that she had gotten her master's, and she was very involved with teaching the patients and doing nursing protocols. And I found out where she moved in Arlington Heights, Illinois, Kathleen Grady, and I hired her immediately. And she is really the one who was responsible for putting all the nitty-gritty stuff together for Loyola's heart transplant program. In the meantime, the referral base kept coming in, and in 1982, I provided probably about a quarter of the transplants that Stanford did from Chicago, and Stanford was sending transplants who lived in the Chicago area who needed follow-up to me, so that I developed experience with transplant patients who were transplanted at Stanford. And then we did our first one at Loyola in March 1983. And we were the 13th program in the United States to start at that time.
Do you remember that first case? What can you tell us
Very
about
well.
that?
Well, he was a 21-year-old kid with dilated cardiomyopathy, was very ill. The unique aspect of him is he had albinism. And so it was very interesting that, there was a lot of press coverage because there weren't any done in Chicago at that time. And the press kept asking whether his eye movements were which were a part of albinism, were caused by his new heart. And there were a lot of myths that I suddenly realized I was going to be put in the midst of. But he did very well. He lived almost 20 years with his heart. And we started our program, and it took off.
So you started the program in 1983, and so by the end of the 80s, which was a time of very rapid growth, how many transplants were you doing a year during that time?
Well, at Loyola, I left in '86. I moved to the University of Utah in the Utah Cardiac Transplant Program as medical director. Jay Mason and Michael Bristow, who were Stanford cardiologists, opted to move out to Utah to redo their cardiology division at that time. And they set up a program that was a community-based program. It included both LDS hospital as well as a university. And they recruited me to come out and be medical director of the program. And that program grew extremely rapidly, whereas in Chicago we were doing 30 to 40 a year. Within a matter of 3 years, we were doing 70 to 80 a year in Salt Lake City, and for 3 of the 5 years I was there, we were the highest volume program in the country. But that patient base allowed us to really get into some meaningful clinical research, I think. And in fact, I think in the late 80s in general, we began to see clinical research that was beyond anecdote in heart transplantation, and an explosion in development of immunosuppression at that time, which was really exciting to be a part of that.
Yeah, that must have been a really exciting time. And the Utah program grew so large, as you say.
Yeah, it grew within 2 years. It was just amazing. But, we were in a unique geographic area. We had between the Stanford guys connections around the country of people who had trained at Stanford, and with my Midwestern connection, we actually brought a lot of patients from outside the Salt Lake community. In fact, less than half of our patients were Utahns that we transplanted. We almost transplanted as many from New York City as we did from Salt Lake City. And we were able to get donor organs because we were surrounded by states that had no transplant programs.
Right. So it's the typical geographic considerations when you're building a program like that.
Right.
So the other thing that Utah has an enormous reputation for, of course, is the contribution of the pathology group to this enormous heart transplant program. Can you tell us a little bit about that?
Well, since we came from other places that we were so used to looking just at biopsies for histology, everybody recognized there were conditions in which we had allograft dysfunction with no histologic correlate to it. Liz Hammond started looking at the possibility of antibody-mediated or vascular rejection. She was a renal immunopathologist, and her background evolved naturally in this direction. We thought she was a kook, because she would call us and tell us this patient is really sick, they have antibody-mediated rejection, you have to do something. And we'd look at each other and say, the patient's fine. So we wouldn't do anything. And this would go on, but when we got patients who had allograft dysfunction and hemodynamic compromise, she would come back and give us the same phone call, and then we would treat them as though they had antibody-mediated rejection and bailed a lot of people out we didn't bail out before. And so we were all believers in the concept. We just didn't know when there was a threshold that we would institute treatment. And still today, Liz remains a powerhouse in that arena of antibody-mediated rejection. And hemodynamic compromise is integral to the algorithm of treatment.
Well, yes, I mean, that same topic dominates our conference this week, and it's really interesting that we're still asking the same questions, and the folks from Utah are still helping us out and providing a lot of the right
I can
answers.
remember one time when Liz went to we were on a junket in Germany, and she was asked to give a talk about antibody-mediated myocardial injury. And she gave her talk, and Eckhard Olsen, who was the premier European cardiac pathologist at the time, got up and said, "My dear, you don't know anything about pathology." And she handled it, but afterwards she kind of was really taken aback by that. But it's an example of how when you have new ideas and you stick to those ideas, initially you're considered an outlier, and over time, if you're right, it'll bear itself out.
I think those are wise words. We see that again and again, don't
Yeah.
we? Of the various protocols and things that were developed there and the impact of clinical research on those, what's your most abiding step forward, your memory of a step forward?
I think the work that we did that probably, I think, was perhaps the most daring, but also turned out to be borne out long term, was the introduction of steroid-free immunosuppression in heart transplantation. Mm-hmm. We spent a lot of time working with OKT3 and trying to understand whether induction therapy meant anything or not. In reality, it's still a controversy. But I think more and more programs have adopted the steroid-free protocols, either with an early corticosteroid administration with a long-term tapering or discontinuation. And I think that has been very beneficial for the population in general, because I can remember when you could identify a heart transplant patient from in any waiting room because they were Cushingoid and their bones were falling apart, and they had all these bad infections and all of these ecchymoses, and it was something that the patients really couldn't wait to get off steroids, and never minded being pulsed with steroids again as long as they didn't have to maintain it long term. We also worked with methotrexate in developing that. We worked with mycophenolate mofetil in heart transplantation as one of the early centers. And so it was really an exciting time. And we actually were doing enough transplants where we had enough patients where we could actually publish some single center results that meant something. But in the same token, it was the era of collaboration among transplant centers that evolved in the 80s as well. Initially, I was involved with some of the other gray-haired cardiologists here in the development of what we initially called the Working Group of Transplant Cardiologists, and that evolved into the Transplant Cardiology Research Database, and then evolved into the Transplant Cardiology Research Database, which became the Cardiac Transplant Research Database, which became a very meaningful registry collecting data that simply couldn't be collected on an international scale. That was headquartered out of the University of Alabama at Birmingham. And so that was something that evolved during that era too. So you had some centers who could do some single center meaningful studies, and other centers that by the nature of their volumes if they were to make a contribution, had to do collaborative work. And so seeing that evolve was also very gratifying during that period of time.
That spirit of collaboration that came during the 80s, where the field was expanding rapidly, the patient numbers were exponentially growing, and yet, as you say, there was a real effort, I think, looking back on it now, to collaborate around the country and certainly around the world as well. Do you find that that's changed? Do you think there's still as much sense of excitement and need to talk with each other as there was?
Well, I think there is a sense of that. It's not quite like it was in the beginning. I mean, if you would have been to our initial ISHLT meetings, or the International Society for Heart Transplantation meetings back then, I started with them. I went to the second meeting, was my first one. And I was not there for the initial meeting in November 1980 at the American Heart Association. At that time, we were rotating them between the American College of Cardiology and the Thoracic Society. And everybody knew everybody else. It was an era before cell phones, but we all knew how to get hold of people. And cardiologists were just evolving into the arena. You know, Sharon Hunt was probably the first transplant cardiologist. Sharon Hunt and Michael Hess, who was the first president, were cardiologists. But other than that, the field was largely surgical field. What happened was that there were a group of us who got to know each other extremely well, maybe 20 of us, and initially commiserated with one another, but in reality recognized that our closest allies were our surgical colleagues in our institution, and they welcomed us into the International Society for Heart and Lung Transplant. And so it was really a special place in the early 80s, mid 80s. I think there's a couple of realities that occurred that changed it. One was, as we were able to collaborate across oceans, we became a truly international society, even though there were a handful of Europeans who were involved early in the game. Once we became a truly international society, then there was concern that we would be in a position where we would not be doing sufficient transplants to justify our existence, because despite the fact that we had all of this great hope that with various legislations in various parts of the world we would increase the rate of organ donation, it was by the end of that decade we hit a plateau in the United States. And once that occurred, reality kind of set in for us. But the ISHLT had the foresight to say that we are going to be more than just a heart transplantation society. We are going to be a society that deals with end-stage heart failure, that deals with the evolution of mechanical circulatory support, that welcomes the pediatric community, that welcomes the nursing community, who is so integral to our success, and that welcomes lung transplantation as that evolved. And I think it was that recognition and that collaboration that created the organization we have today.
So in 1991 to 2, you served as the 8th president of ISHLT, which would have been around the time of that sort of plateau in numbers, I suspect.
Correct.
What were the highlights of your year as ISHLT president? What were the issues that you really had to...
Well, the first highlight was an organizational issue. We were unhappy with our managing company. And it was a painful and legal decision to get rid of them and move in a different direction. And I remember when Amanda Rowe walked into my office, and I was actually chair of the Department of Medicine at the University of Mississippi then. And we just hired her as the new executive director of the organization. And she was impressive from day one, and I knew that her vision of this organization was the right vision for us. So if I was to characterize that year and a half that I was engaged, it would first and foremost be the organizational change, bringing Amanda Rowe into the organization. The second issue that we dealt with is we became much more of an international organization at that time. In fact, I was the program committee chair for the first meeting in Paris. And we had to grapple with the realities of what we were going to do if an international incident occurred and how this small organization was going to survive. It happened to be that occurred. Our first meeting was in May I think that was 1990, I believe, and no, B91, one of the two. At any rate, the Desert Storm occurred earlier. The first Desert Storm occurred earlier, and there were all kinds of warnings about Americans shouldn't travel overseas. The society was 2/3 American at the time, so there was a serious concern that the society would be devastated financially, and there was discussion about canceling the meeting. Fortunately, we went ahead with it, and fortunately, cardiologists and cardiac surgeons and less so nurses came and participated in the meeting, and it was a successful meeting. The other thing that happened during my term as president is we decided to codify the whole concept of having separate disciplines in the organization. So we created the counselor system, a bit modeled after the American Heart Association council system. Fortunately, because we had advocates for the pediatric community, we had advocates for the nursing community, we had advocates for the specific cardiac surgical related issues and mechanical support, and we had advocates, lung transplant was just evolving then, and we created those councils, and those councils actually have flourished in the last, gosh, it's 19 years.
Gosh, that's really interesting, because we struggle with some of those same issues still, but there seems to me to be it's of great importance to the membership to maintain the international feel of the society.
Well, it's something that we all have to, it's very easy to get, John Walwork used to accuse me of being xenophobic all the time, but that was just John Walwork's way of reminding me about the international nature of the society. Because I think that because it started in the United States, and it was initially dominated by Americans, that we used to look at it, it was something that actually took work on the part of the society to really encourage people from other countries to participate and to call it their own, because there was a danger of creating similar societies in other parts of the world. And fortunately, the International Society for Heart and Lung Transplant, because of its acknowledgement of the fact that we're one big community, it worked out extremely well. We had an international registry. Yes, we had a component that was mandated in the United States by UNOS, but we had an international registry and always maintained it that way.
Well, I think that's certainly something that maintains huge importance and value to the flavor of the society today, even as we struggle with maintaining and creating new registries, which kind of brings us to another area that I know you've been involved with for a long time, which is the development of mechanical circulatory support. How did you get interested in that, and was it through what you saw as failings in taking care of heart failure patients?
Absolutely. I mean, I think that it was, there are several things that led me to that. First of all, I was fascinated by the whole Barney Clark story, and that had to be part of the attraction to move to Salt Lake City, even though by the time I got there, Rob Jarvik and Bill DeVries had already left Salt Lake. The other issue is that the biggest frustration we experienced in the late 80s was that as the list grew and the number of transplants didn't grow proportionally, there was mortality rates that approximated 30% on the waiting list. So when you had a 90% one-year survival rate, it was actually more dangerous to be listed than it was to be transplanted. And I was pushing at that time to say, maybe we should look at this as an intention to treat analysis. From the moment you decide a patient needs a heart transplant, what is the likelihood that patient will be alive a year later? To date, we've still never seen data presented that way. But clearly, we needed to have something. Now, there was enthusiasm about xenografting in the early 90s, particularly when some genetically manipulated pigs were developed that expressed human decomplementing genes. And so there was actually, in the late 80s, early 90s, there was serious discussion as to whether we would ever have a mechanical device that would be as good as a xenograft. We had no idea that we would have the kind of devices we have today. And quite frankly, looking back on it more than 20 years later, it's very clear that probably the greatest contribution that's been made in the treatment of stage D heart failure has been mechanical circulatory support.
Do you think we'll see a resurgence of interest in xenotransplantation over the next few years, or do you think that will continue to wane?
I hope we do. I mean, I think that there are aspects of a biological heart that make a lot of sense. I think that the limiting factors, a lot of them have to do with viruses that have been identified and trying to understand whether those viruses would be dangerous in a human, particularly an immunosuppressed human. But I hope that we have a biological solution. The biological solution may not be a xenograft, though. Biological solution may be a form of cardiac regeneration. simplistically with stem cells, or even some of the dramatic work that's being done by Doris Taylor at the University of Minnesota, where she takes a fibrous scaffold and can grow a whole new heart with stem cells. You know, that is science fiction to me today, but a lot of what I see today was science fiction to me 25 years ago.
That's a wonderful recollection. Just to step back again, an area of interest that we only touched on briefly was your earlier work with beta blockers and their early use in heart failure. I believe that at the time, all of us were being taught that beta blockers were contraindicated in heart failure, and yet you were able to really work very carefully in this field, and the whole concept has turned around and changed now. What was it like working kind of against the stream for a while there?
Well, it was that way, but there were people who believed from the very beginning. You know, we were all intrigued by the report out of Göteborg, Sweden, back in the late 70s, that people got better on beta blockers when we were all taught that they were absolutely contraindicated. And I actually, when I was at Loyola still, we conducted the first randomized controlled trial of beta blockers in heart failure. It was a small trial published in Circulation, but it certainly kept our interest going. And one of the reasons I moved to Salt Lake City was not only to be involved with the transplant program, but to work with Michael Bristow, who was and still is, in my opinion, the leading translational researcher in the role of the sympathetic nervous system and the role of blocking that in the management of heart failure. If you were to poll heart failure specialists of my genre as to what is the thing that made the most difference in the management of heart failure, every one of them will tell you it's beta blockers.
It's nice to look back on that and say, you know, the research, the important component of translational research here, because in this day and age where research funding is more and more difficult to get, that's clearly been a seminal accomplishment in the field. What would you say to young people who are heading out today as far as their potential role in heart failure and heart transplantation? What do you see as the next challenges as we move forward?
Well, you know, as we're entering a pharmacogenomic, a molecular, a cellular, and a grow your own organ solution to the problem, my advice to them is that what looks like science fiction today may be your clinical reality, and you can play a role in it.
Well, that's a wonderful thought to end with. Thank you very much for participating in this project and for sharing your thoughts with us.
Thank you, Laurie. It's been a pleasure.